and you on the Cybersight. Since we are in the COVID times, we are all used to wearing masks. And I was just wondering that in adjustable sutures also we have similar differences of sliding noose or a 1.5 knot technique that we are seeing in the masks also, as you see here. We need to be adjustable. You need, if you don't have a Ford, you have an Oxford, and you will be more successful if you are adjustable. Adjustable strabismus surgery, if we see the history, it was first suggested by Harms in 1941. But if you take into account the German literature, it was mentioned by Bilshowski in 1907 when he described Sattler performing a similar procedure. It was revisited by Jampolsky in 1975, and then there has been a rejuvenated interest time and again. We need to be having this in our armamentarium because the indications will be first and foremost those which are having incomitant strabismus. If you have a sensory anomaly in which the end point is not very clear, then again we have a problem. Reoperations when the patients are more demanding, when there is a vertical strabismus or a combined horizontal and vertical strabismus, and whenever the end point is more discrete and the patient is more demanding, you would have to have an adjustable surgery. Much more so for the incomitant strabismus, which are having diplopia, and the patients would be wanting a diplopia-free position. So whether it be a 6th nerve, 4th nerve, or 3rd nerve, or even in the restrictive strabismus, particularly the dysthyroid eye conditions, or an ortho DRS, which may be a very troublesome thing if you do not have an adjustable on your sleeve. Post-RD buccal surgeries or glaucoma ball surgeries are again very definitively demanding, so we will have to do. The contraindications, of course, are those children who are not going to cooperate. Even apprehensive adults who behave like children may be uncooperative. High myopes, thin sclera, or an inferior rectus, we may have a problem, and we have to be careful that we don't use an absorbable suture, otherwise there is a progressive recession. The published studies on adjustable surgeries are inconclusive. As you see, there are 18 studies described by Nihalini and Hunter in the eye in a very good review in which they have shown. But unfortunately, you'll find that mostly are retrospective, non-randomized, and the numbers are not as much to give us a definitive answer. Even the Cochrane review, again, time and again, even in the latest one recently done, has been inconclusive, and it doesn't tell us because there are no randomized controlled trials between these two. But whatever studies we have seen definitely show that the success rate improves between the non-adjustable and adjustable, and a difference of at least 10% jump is there when we use adjustable surgery. So the reoperation rates fall from 20% to 9.7% as shown by Wisnicki, and definitely we can adjust at the time up to 20 prism diopters at the adjustment. So whenever you have a demanding patient in which we want an exact result, whether it be for a cosmetic reason or for a diplopia free, you would have to do this technique. Let's see what are the different strokes that we are going to play. First of all, it may be preferable to do a limbal incision, although it can be done with the fornix incision with a retractable suture placed to help you expose that. Secondly, we are going to pass the sutures, the needle radially as shown here. It may be a full hangback or a hemi hangback, in which, like in this case, we are showing you a hemi hangback in which we have passed in the sclera and then again in the insertion side. The third thing is that I am going to place a releasing suture, a silk suture between the sclera and the first knot, so that it helps me in releasing the knot at the time of adjustment. You need to see that your suture moves in the tunnel. So check that at the time of surgery so that it makes your life simpler. And this 1.5 knot I am placing instead of the regular one. The silk suture is tied as a loop knot. And finally, we have a bucket handle suture, which will help me hold the globe and not depend on a fixation forceps. Sometimes the tissues can be cutting through with the forceps. So you need to have a firm grip on the sclera. So these are the few different techniques or strokes that we'll play. There are different techniques of adjustable strabismus surgery. It may be a hemi hangback or a full hangback as in shown A and B, or it may be a sliding noose technique as preferred by some people. When do you adjust? It may be done intraoperatively as a single stage adjustable surgery using topical or IV conscious anesthesia, or it may be done as a double stage, which is the more commoner method. It may be done after 5 to 6 hours, although some people do it between as 2 sequential GA, and even after 1 hour adjustment may be done. After 24 hours has been also done by some people, and there has been a study by Valley's group who have shown that there is not much difference between 5 to 6 hours or 24 hours. Even delayed techniques have been described. The technique that I usually follow is what I learned from Dr. Rosenbaum, and the simple instrument that you will require for adjustment are shown here. You may require a tetracane or a paracane drops. If you find the pre-op patient who had an exo has gone into a post-op over or under, you can adjust it accordingly. You just need to release the 1.5 knot, and for decreasing the recession, you hold the globe and pull the suture so that the recession can be reduced. Or if you want to increase the recession, you hold the globe and ask the patient to contract that muscle so that it recedes further. So both are possible, and for this reason, you may do an optimal surgery and not do an over recession as it was initially mentioned by some people. The sliding noose technique is another technique, but my preferred technique is the 1.5 knot, and that is what I have shown here, and we can do it. In children, Hakim has shown that you can do a 2 more millimeter recession, more effect which can be added, and this can be released by the releasable suture, and you can have like 2 options. Similarly, Helveston has shown as a tandem suture technique which you can have. The Farden has also been used as an adjustable suture, as we were just talking about by Dr. Molinari's talk, and this is especially so when we have a near distance disparity, when we want a more exact end result. Similarly, the superior oblique tuckings, we always do an intraoperative adjustment. This is also considered as an adjustable procedure in a way. And the Harada Ito can also be done as an adjustable procedure to get the end result of torsion more accurately positioned. Coming to the 6 nerve palsies, which we'll be talking about more detail in my next talk, the adjustable cross-section partial VRT as shown here is a very definitive advantage compared to the non-adjustable, in which you may have either an over or under correction, which may not be desirable by the patient. And as shown in this study, in these 10 cases in each group, they found in the adjustable, there was only 1 case which was 8 or all were less than 8 millimeters prism diopters. Whereas in the non-adjustable group, we ended having 5 cases and we could not adjust. So it is always better to have an adjustable technique on your sleeve. So to conclude, adjustable sutures provide a more definitive alignment. It requires a special technique, extra efforts are required, and you may not require to adjust in about 50% of cases when you are doing an adjustment. It is definitely a double trouble, but in demanding cases of diplopia, it offers a second chance or a safety net to fall back upon. So I would say whenever you have a very demanding patient, you should try to do this technique so that we can definitely give an alignment in each type of surgery that we do. Thank you.
Thank you, sir, for an excellent presentation. The questions, I think the questions are coming in, but one question which is written is that, so Dr. Yuvika has asked, sir, has you pointed IR as a relative contraindication? Can we do IR recession and adjustable in thyroid? We do adjustable in the inferior rectus and thyroid.
Yeah, you can do adjustable. What I mentioned, when you have to do a adjustable on a inferior rectus, it is preferred to use a non-absorbable suture, especially in thyroid cases, because you may have a posterior slippage or over recession effect over a period of time. This has been reported by several people. So it's preferred to use a non-absorbable suture when you do a thyroid inferior rectus. A tight inferior rectus against the bells, which usually tends to recess more.
So there's no question, but sir, do you find the noose technique, the 1.5 technique better than the noose technique? Any special,
yeah,
I switched because I was doing the noose.
In the noose, I have a fear that it may slip beyond my control. Okay. So because of the
because tightness, I feel in granuloma, the noose technique was a concern. Do you?
Okay, so that's why I usually do not do a noose technique, and I find a 1.5 knot can be easily pulled forward or backward and give a final end result. So I usually prefer to do a 1.5 knot. But yeah, there are people who do a noose technique, and it's fine with them.
So there's a question they're asking you, how much do you split the muscle for Farden? I think this was for the DVD. How much you are going to split it for the superior rectus?
I would have to split at least 10 millimeters. And the separation between them is not as much as we do for a DRS, that is 20 millimeters for DRS. Here the splitting between the two ends of the superior rectus is about 8 or 10 mm, because this is what we just need to do a Farden effect. So now I will be talking about the vertical rectus transpositions and the modified Nishida procedures for Abducens palsy. I have no financial disclosures to make. The management goals in 6-nerve palsies, as we all know, are to bring the eye to the primary position, to correct the head posture in the same manner, to provide diplopia-free vision in the primary gaze, to improve the abduction amplitudes, and finally to expand the field of binocular single vision. So let's say if you have a 6-nerve palsy, we have seen the transposition procedures have evolved over a period of time. In 1907, Hammersheim had described the partial VRT. There have been several modifications since then, and each one has added value to it. Whenever we have a partial VRT to be done, we know that the effect may not be as much as desired. So there have been techniques to augment the force by adding a resection to the component of the muscle which is being fixed, or Scott Foster suture, an augmentation done by posterior fixation suture, which is past 8 millimeters to vectorize the force in the direction of the paretic muscle. This has also been done for a partial VRT as well as for a full thickness VRT. And there is an article from Velez Rosenbaum group in which a partial VRT with posterior fixation sutures were shown. But the problem with these techniques is that there is no ability to adjust. And if you have a desired result, it is fine. But as we have seen, it may not be all the times. And you may sometimes have an under or an overcorrection. And even an overcorrection may not be so desirable as the patient will be unhappy. So Guyton described a technique in which he was using a cross-action, full-width vertical rectus transposition so that it could be put on an adjustable suture. And this is a very interesting technique. But since we are using a full width, there is a risk of anterior segment ischemia, especially if you have to add a medial rectus recession as the antagonist muscle. You would have handled 3 muscles. So we thought that why not do it with the partial VRT. So what we have described is a partial VRT on cross-action sutures as shown in this schematic diagram and the picture here. I will just show you a video which will show you first the conventional VRT, a partial VRT, using a resection to augment the effect. So this is what we have split the superior rectus. Usually we try to save the vessels as much as possible, and sometimes even this half of vessel may be saved. Now 2.5 millimeter resection effect we have developed in this by passing the sutures 2.5 millimeters away from the insertion. So we will be effectively resecting this part of the muscle. In any case, whenever we are using the superior rectus for lateral rectus, there will be an augmentation because the arc of contact will be stretched when we are putting for a lateral rectus. And now we are passing the superior rectus at the upper edge of the lateral rectus. Now this is how we can do a conventional partial VRT. Similarly, the inferior rectus is passed, and as I have shown you that it can be put on an adjustable suture intraoperatively or even as a 2-stage. You can keep it as a 1.5 knots. This will also help in correcting any torsion effect or a vertical effect. For a cross section, the technique is similar. You just bring the superior part on the inferior end and the inferior part on the superior end of the lateral rectus. As you see in the schematic diagram here, and you can put them on an adjustable suture, or if you are confident, you may put it as a non-adjustable suture and do only an intraoperative adjustment to see that there is no torsion or a vertical, significant vertical deviation that you have created. But if you have to be more sure, you can keep them on adjustment and adjust it after 6 hours. We had done a study comparing the adjustable and a non-adjustable group. As you can see here, the pre-op large angle esotropia which was there has been corrected fully. The abduction has improved, and the distance deviation was improved in both the adjustable and non-adjustable techniques. And similarly, the binocular vision was also improved, but it was larger improvement or more improvement in the adjustable group compared to the non-adjustable group. And similarly, the abduction improved in both the groups, but slightly better in the adjustable group. So coming to the dinner plate that you have now, the options that you can have a partial tendon VRT, a full tendon VRT, or you may have a single muscle SRT or an IRT as described by Hunter's group. You can also add on the effect by augmenting by a resection as shown here, 2.5 or 3 millimeters. You can add an effect by a Foster sutures, or you can also augment by a cross-action suture. You can also increase your effect by doing an antagonist medial rectus recession. Sometimes if you have a full VRT, you may not be able to do a recession. You may just use Botox in the medial rectus. And you can also have a additional effect by doing an lateral rectus plication. So you have a full plate for your dinner right now. But this is not enough. We have the dessert still left, and that's the Nishida's procedure. So the Nishida's procedure is a very useful addition to our armamentarium that we have. Here we are not disinserting the superior or the inferior rectus. We are not even splitting the superior inferior rectus, but just vectorizing the force, passing a non-absorbable suture, 8 millimeters in the muscle, and then putting it closer to the muscle that we want the effect to. And these are the pre-op and the post-op pictures. Let's have a video to see how it works. So in these two vertical recti, the same way as we did for the VRT, we are going to identify and free it up to 8 millimeters, mark it at 8 millimeters. Non-absorbable 5-0 ethibond suture is what I like to pass in the 1/3, lateral 1/3 of the superior and the inferior rectus. We also need to ensure that the nasal part of the intramuscular septum is spared or freed fully so that the muscle can be easily switched towards the side that we want to switch. And then 13 millimeters from the limbus in the sclera, a passage is made and with both the needles. And then again, I pass it in the muscle. So this is the muscle, sclera and muscle technique again, which will reinforce the vectorization fully in the direction of the absent muscle or the weak muscle. This is a very simple technique which is being initiated by Dr. Nishida's group, and we have modified it slightly that we vectorize a little more towards the missing muscle, and the effect is very good. It can correct up to 35 to 40 prism diopters easily. And as we have seen in this study, we'll close this here. This is the pre-op and post-op pictures. In the non-adjustable group, when we did the Nishida's procedure, we found that we had overcorrections in several cases. And in one case, it was very severe to about 30 prisms. So we need to have an adjustable medial rectus whenever we do a Nishida's procedure in order to have a more definitive result, as we saw in this group, in which the adjustable medial rectus recession takes care of the overcorrections. The preoperative fields have been centered and enlarged in the dimensions. The abduction amplitude has improved, and the anterior segment ischemia has not occurred, which we should be always careful in all the VRTs and examine the eye under the slit lamp on the first post-op day so that there is no anterior segment ischemia signs. The series that we have seen in the reviews, there are several studies which have been done. We have found that because the techniques are so different and each one does it a little differently, there is no conclusive answer. But we definitely know that the single muscle techniques are less effective than the double muscle techniques. The partial vertical rectus transposition will be less effective than the full width transpositions, but there is a risk of anterior segment ischemia. So our choice would be to use an adjustable cross-section partial VRT to get a more definitive and predictable correction, and in addition to the medial rectus recession. And in the Nishida's group, whenever we are doing, and we may have an adjustable MR whenever it's possible, like we are operating on an adult or a cooperative child, this would be our preferred technique. So to conclude, I would say you need to have different techniques in your armamentarium. As this study has shown recently, and I also have seen once that I had to do, when I was doing the partial VRT, the inferior rectus partial stump just gave way, and I was under a dilemma what to do. So I used the inferior rectus Nishida's technique, and the superior rectus was of course done with the VRT technique. So you can have a combination of different techniques to get the desired result. I would like to thank you at this point and for your questions. Thank you.
The questions is like, what is the ideal age for VRT?
We have done in children, maybe even a child with 3 years old, I have done a VRT, as well as the lateral rectus split and medial positioning also I have done in 2.5 or 3 years old children with a large third nerve palsy with a large exodeviation. But in 6 nerve palsies, again, if you have, fortunately we do have less 6 nerve palsies, but when we have a DRS cases, we may have to may do children also in with the VRT in younger children.
There is in modified Nishida, how do we achieve shifting of the muscle without splitting? I think it's your modified technique which they're asking.
Yeah, what we need to ensure is split the intramuscular septum on the nasal side so that the superior rectus can be easily transferred towards the side that you want. And secondly, you need to pass a reinforcing suture. That means first in the muscle, then in the sclera, and then a bite in the muscle again. This will bring the muscle in the desired position. But we need to free the intramuscular septum on the nasal side.
Okay, so I'll start sharing my screen. I would be speaking on, I think, a surgical controversy, which is a